meantime, I'd like to thank Mark and Miguel for the invitation to come and present to you today. It's a very interesting opportunity, and what I'm going to talk about is really the medicine of the future, which is going to be quite different from the medicine that we currently undergo, and is going to be much more concerned with you as an individual than we currently know. And this is because the medicine up to this point has really been aimed at increasing the wellness of all of us. So through things like improving water and nutrition and sterile procedures during operations. But now we're moving into an era where it's much more individualized. Okay, this is good. So we're now getting back to the presentation here. I'm going to talk about the personalized medicine revolution, and which is going to change diagnosing and treating disease completely, forever, very soon. And you will find this to be one of the biggest revolutions that you've ever experienced. So how do I turn this thing to the next? Okay, so why do we need personalized medicine? It's fairly obvious. Many drugs that we take either don't work for you or harm you. And so we need to determine who's going to benefit from a certain treatment and who will not. So avoid what we currently use, which is trial and error therapy. I mean, you go to your doctor, he diagnoses a disease, or whatever might be wrong with you, he might prescribe something. If that doesn't work, he'll try something else and then something else. That's the trial and error therapy that we're currently enduring. The other problem is that we're in a reactive medicine mode, that we're treated after we get ill, which is obviously in many cases too late. We need to have indications that we're on the wrong trajectory, and then be treating people before they get ill, treating you before you get ill, as opposed to after. And so these are the things that the personalized medicine or precision medicine agenda is going after. So our current medicine is really a one-size-fits-all approach, as I indicated, and the problem is indicated here on this slide is that we're all really very different, and we're very different in fundamental ways. We're different in genetic makeup. There's up to 3 million. We have 3 billion base pairs in all of our individual genomic DNA. We differ in about 0.1% of those from one person to another. That's 3 million differences between you and anybody else. This can obviously things like sex, ethnicity, physical appearance, other abilities, physical abilities, etc. We have different clinical backgrounds. We've had obviously of different ages. We have different comorbidities, different diseases. We've taken different drugs. We might be taking a bunch of drugs all at the same time. Different environmental factors. This is the environments. One of the primary environments are the bacteria that live in and on our bodies. So those can differ substantially. And obviously we have differences in lifestyle, nutrition, and exercise, and all those things. So we need to take all of those things into account when we're dealing with you as an individual suffering from some particular condition. And so this is really all enabled by technology. So presently we have late diagnosis, as I indicated, one-size-fits-all therapy, but technology is really enabling us to move from the current paradigm where you go and visit your doctor, he examines you and makes a diagnosis and a prescription on that basis, to personalized or precision medicine, where you get a molecular diagnosis, in other words, molecules in your body measured, and your diagnosis based on that. That can lead to early diagnoses, much more individualized therapy, getting drugs that will work for you, and then preventive care that's based on that information. So this is really enabled by rapid technological change, as is indicated here. There's enormous forces driving this new form of medicine. The rapid technological change is one, as Mikhail indicated in his introduction. The costs of genome sequencing are going down dramatically, as are the costs of every other way of measuring things in your body. And then we have information technology that is now able to deal with all that information and get realistic information back to you. Patient safety, the fourth leading cause of death in North America, and I would suspect also in Europe, is an adverse reaction to a prescription drug. And so we all want to avoid that particular circumstance. Those adverse reactions can be obviously pretty nasty. They're a good percentage of the healthcare budget. Drug efficacy, less than 50% of drugs do not work on you as an individual, so 50% of all drugs that are prescribed are completely useless, in addition to having the potential to harm you. Consumers are now demanding, obviously enough, that this is stating this is an untenable situation. They want individualized and non-effective and non-toxic treatment. And we need to be able to practice preventive medicine. We need the information to know what we should or shouldn't be doing in order to maintain our health. And so these are forces that are irresistible, and they are going to have a major impact. So this slide has already been alluded to. The cost of genome sequencing has now gone from $1 billion in 2000 to about $1,000 today, and can be done in a couple of hours. And so this is just one example of how you can be measured as a human being in a very quantitative way, and it has very direct implications for your health. So just bringing a few numbers up here, I mentioned patient safety, adverse drug reactions, 100,000 deaths a year in North America. So probably similar sorts of numbers in Europe. It's the fourth leading cause of death. Here's an example of these kinds of toxicities. A common cancer drug is doxorubicin. It's used for 70% of childhood cancers and breast cancer patients. There's over 1 million doses given every year. It's very cardiotoxic, at least it is for certain people. So 10 to 30% of patients suffer heart failure as a result of this drug. It's increased, that's increased in children. It can cause death, require heart transplants. Some people are much more susceptible than others. But right now, everybody gets it because that's the standard therapy. There are now genetic tests that they're being brought in that can identify those people at a particular risk, and there are alternatives that can be used. So this is a 12-year-old boy, presents with pain in the abdomen. This is actually a case in Vancouver, diagnosed with lymphoma, undergoes chemotherapy. For the second round of chemotherapy, becomes short of breath, diagnosed with heart failure, and then requires a heart transplant. So not only does he still have cancer, he now has to have a heart transplant as well. The drug, so in addition to causing those kinds of problems, only 25% of cancer drugs actually work on the individual they're prescribed for. And so we have a double whammy. You're giving people drugs that not only they may not need, but in addition, they're making them extremely ill. So these are the reasons, and I think they're pretty compelling. And so how can personalized medicine help in this kind of scenario? It's fairly straightforward. If you have a patient group that has the same diagnosis, currently what we have is the same one-size-fits-all drug prescription. But really, those patients, individuals in that group can be grouped into groups where the drug is not toxic and is beneficial, so obviously you'd go forward and treat those people. Other groups where the drug is toxic but not beneficial, so you wouldn't give it to them. The drug toxic but beneficial, maybe you give a lower dose. Drug does not work and is not beneficial, you certainly wouldn't give it to those people either. So we need these molecular profiling processes on individuals, and it's called stratification. We need to get them into groups that get the appropriate therapy. And so an example of this is for genetic test for cancer treatment. So as I mentioned, 75% of drugs don't work, and all cancer drugs are toxic. So we can sequence the cancer genome to determine the cancer causing mutations, and you can choose the drugs you use on the basis of that information. And then you can sequence the normal genome to find out whether you're going to have an adverse reaction. And so you come back with a selection of drugs that are more appropriate to that individual. So this is the type of scenario that the cancer treatment is moving to very, very quickly. That we test people first of all to see which drugs are going to be safe and effective, and then match the therapy to the individual. So this can dramatically change people's lives. This is a patient in the cancer agency in Vancouver. She was diagnosed with Trish Keating is her name. She was diagnosed with colon cancer 4 years ago, had multiple rounds of chemotherapy, relapsed 4 times, and she has stage 4 cancer right through her body. Sequenced the cancer genome and found that one of the drivers of the cancer was a protein that that could be blocked by a drug that was already on the shelf. That drug is normally used to treat high blood pressure. And so then when treated with that drug, her cancer disappeared within a couple of months, and 1 year later she's in remission. But it just shows how these individualized and targeted approaches can have profound effects. So what about drugs for other diseases? The more drugs, obviously we're talking about cancer drugs, let's talk about drugs for other disorders. There's about well over 1,000, on the order of almost 2,000 drugs that are commonly given to people. The more drugs you take, we're a drug, obviously overly drugged society. The more drugs you take, the greater chance you have, of course, of an adverse reaction. 20% of people over the age of 65 in North America take 10 or more drugs every day, so this is a huge potential for adverse reactions to a drug, and also there's drug-drug interactions that can cause further problems. This cartoon is giving this doctor is giving this patient a whole list of prescriptions, one drug to treat the original problem, and then other drugs to treat problems that might arise as a result of being treated by that drug. I should say that that projector back there isn't working either. I don't know if that's could be fixed. So there's, as I mentioned, there's over 100,000 deaths per year are due to adverse reactions to prescription drugs. And there's a solution here for approximately 200 common drugs that are very commonly used. There's genetic guidance in the package insert. So this is the insert that comes with the medicine. It's really not currently used because your doctor doesn't have a clue what your genetic profile is. But what's coming onto the market now are genetic tests to guide prescriptions. So in other words, you'll get an advance warning that you maybe shouldn't take that drug, but there's another one that should be taken. And so this is the problem that the doctors face. This is a drug package insert, and on there is information about the genetic profile or the genetic problems that might be associated with that drug. Well, clearly, your average doctor doesn't have time to read through this and prescribe on the basis of that. So you need a completely different approach. And so this is the approach that's being used or being employed in some pilot projects in British Columbia, where the patients are get a small genetic test. It's entered into their electronic medical record. When they go to the physician because they've got a problem, the doctor diagnoses their condition. It types that into the electronic medical record. Genexus, which is the company we've set up that's marketing this, provides an algorithm that goes through not just the genetic information but other clinical information, comes up with a personalized prescription that is suited to that individual, leading to fewer adverse reactions and more efficient health care. In British Columbia, we spend $17 billion a year on health care. $2 billion of that is for drugs. Half of that is wasted because 50% are given to the wrong people. And there's also a $2 billion cost for treating those adverse reactions. So there's huge savings that can result from this. But so I've talked mainly about genetics to this point, your genome, but there's way more that we can measure about you. And this is indicated on this slide that you start off, your genome codes for what you are. It does that by making proteins, and so you have a large number of proteins in your body. Those proteins in the food that you eat make use of metabolites, and in your body you have a large number of bacteria. They make products as well that can also be metabolites. So you have, this is just a subset of molecules that exist in your body that we can measure. And so we can measure proteins, we can measure metabolites, we can measure the microbiome, we can measure other things. This is collectively referred to as the omics. So this is a shorthand way of referring to the molecules that are present in your body. So this is all in addition to your genome. Now your blood bathes every organ in your body, and all of those organs leach out proteins and metabolites that are really signatures for those organs. And so if you measure a subset, it's on the order of 20 or so proteins or metabolites that originate from a particular organ or from a particular problem, such as a cancer, then you can detect that disease, you can monitor the progression, you can monitor the effects of therapy and detect reoccurrence. And so what we can do now, as a technological result of technology, is detect hundreds of proteins and metabolites simultaneously in your body for prices that are getting fairly reasonable to diagnose disease anywhere in your body. So these blood tests are becoming very sophisticated. Your microbiome is also a measure, a group of, in this case, bacteria that we can measure quite precisely. They have huge implications for immune disorders, the composition of the bacteria in your gut. And so this includes disorders such as inflammatory bowel disease, diabetes, rheumatoid arthritis, etc. But the point being that we can really measure you, quantify you in a way that we could never do before. And so the future of medicine is rapidly arriving in the form of molecular data clouds for individuals. And so we will be generating our own data clouds, our genomic, proteomic, metabolomic, microbiome data cloud that will allow us to detect the disease early, achieve better stratification when we do get ill, so we get much more precise diagnoses. We'll match the treatment much better to the disease and to our bodies, and we'll be able to practice much more effective preventive medicine. So we've recently started a company to perform these molecular profiling. It's called the Molecular U, and this takes you, and then we get the genetic, proteomic, metabolomic, and bacterial profiles to construct the molecular version of you. So currently, this consists of the whole exome. So this is the region of the genome that codes for the proteins in your body. So this is the codes for about 20,000 proteins, and it's called the whole exome. It's about 2% of the whole genome. Very soon we'll be sequencing the whole genome, but right now it's convenient to do this. The proteins in the blood right now, we're analyzing 240 proteins in your blood, 1,000 bacteria in your gut and your fecal matter, and 300 metabolites in blood and urine. This is really just the start in terms of being able to analyze you as an organism. Very soon, the number of molecules we'll be measuring will be in the thousands. So the molecular U process is that the patient goes to his doctor, says, I want to get this done. Sends samples to molecular U. This is blood and urine and fecal matter. Then the individual omic data cloud is generated. As a comparative analysis that I'll describe in a moment, you get a report back, and then you start to guide your health on that basis. So this individual omic data cloud is compared to the world's clinical information. And so it's basically molecular biomarkers that are associated with more than 300 diseases. Actually, we're closer to 500 now. There's 1 to 12 clinical studies for every disease. You then identify the particular molecular markers that you have that are associated with disease. So the number of diseases here is, I can go on this slide, but it points out heart disease, diabetes, cancer, arthritis, basically every disease that you care to name can be, you can get risk profiles for those disorders. This is an example of an individual suffering from a condition known as polycystic ovarian syndrome, the leading cause of infertility in women in North America, and indicating that in this case her score indicated certainly a trend, a very strong trend towards diabetes, obesity, etc. The interesting thing here is that these are real numbers. You can go back and then say, okay, well, what are the actual molecules in your body that are out of whack here? The green here is the area you should be in terms of the norm, so it can point out how far out of the norm you actually are. And then you have a quantitative measure of basically if you change your lifestyle or your diet or your exercise program, you can see whether things are going in the right direction or not. So it really gives you much more quantitative information to try and treat yourself. So this then leads to a detailed health status report and action plan, an overview, a summary of your health, level 2, a disease report for all the diseases that are possible, at least the major diseases, a summary of the health of all your organs, brain, GI tract, immune system, etc., and then the details. You can drill down if you want to find out just what this information really means, and then you can go all the way down to the scientific literature if you want to go that far. So this is data for me, actually. Luckily, it said I have no overt disease at the moment, relatively low risk for diabetes, a relatively low risk for cardiovascular events, which for me was a big relief because my family has a rather sad history of cardiovascular problems. However, it's so no overt disease detected. That was the good news. I found that my brain health was on the low side. I complained about this, but it turned out. So I had two neurotransmitters. Well, one's a neurotransmitter, the other is a precursor. Carnosine and serotonin levels are low. But interestingly, in this case, there are additives or supplements you can take to start to adjust this condition. Similarly, in nutritional health, vitamin B1 and B3 levels low. But again, there's obvious things you can start to do. And so from this molecular data, you can come up with a health action plan that is basically focused quite clearly on one part of your body or another, or a trend line you may have that's going in the direction of a particular disease. And so this can be involve diet and nutrition, fitness in terms of your particular action plan. And I should say that exercise is turning out to be one of the magic bullets in this whole area. As you might expect, that this can have benefits in many different areas: hydration, stress reduction, the various supplements one can take, adjusting your daily activity, as well as the potential pharmaceutical interventions that one might take. But you can see the trend here. So where we're going is the line in black here, where it goes down to actually where you reach a disease threshold. We want to avoid that. If we're on a trend line towards something that could be in any way life-threatening, you want to catch that well before it becomes a problem through this molecular profiling approach. Find an approach that works for you to bring you back up to your norm, and you're going to have the information that tells you that you are getting back to the norm that you were at before you became ill. So this is really a revolution. Your doctor is going to turn into your health coach, somebody is picking. His job is going to be to pick things up in you that are going in the wrong direction and tell you how it is. Help you using these kind of analysis. Help you analyze how it is you may get back into the right mode. Obviously, huge benefits here. Patient empowerment being a major one. You are going to be in control of your own body, your own life, in a much more direct way. Some of us may find that somewhat nerve-wracking, but it's actually a very empowering process that we will obviously be moving towards much more effective non-toxic therapy and much more effective preventive care. So the revolution has really started. This is 5 events that have happened in the last year or 2 years. More than 100,000 people in the world now have their genome sequenced, and actually it's probably closer to 200,000 now. Cancer therapy is increasingly dictated by the genetic makeup of the cancer, as opposed to whether it's breast cancer or prostate cancer or anything like that. It's a completely artificial distinction. What we need to treat the disease is on the basis of the genetic profile of the disease. The first introduction of genetic tests to guide drug prescription are coming into the system. Their leukemia is now treated by very personalized immunotherapies that are highly effective, and omic profile to guide individuals' healthcare is becoming increasingly available. So it's a very exciting time. I've actually written a book on this, so if you're interested in learning a little more, the opportunity is there. But the changes that are coming into medicine are profound. They're very much IT, information technology driven, and reliant on information technology. And so for a conference such as this, it's highly fitting that you're including the health system in this very direct way into your agenda. It's yet another example of where information technology is completely disrupting the current system we currently exist in. So thank you. So the question is, for anti-cancer treatments that are based on the genetic information, the genome of the cancer, when is that available? Well, the fact is it's available right now. It depends on which jurisdiction you are, but certainly in every major cancer hospital, you're going to find these kind of efforts going on. The problem is getting into those programs. They're very often run by philanthropy, and they are expensive. It's $100,000 roughly to be able to go through one of these procedures. But the demand is increasing, and the resources are increasingly there. So how much data and how many years does it take to get the data? Well, right now it should take less than a couple of weeks. Just taking the the cancer, extracting it, say a biopsy of the cancer, and then sequencing the cancer genome. It's a couple of weeks sort of project. The problem from then on is really doing the bioinformatics of deciphering from all that genetic information what are the driver genes, what are the oncogenes that are really driving your particular cancer. And that can take a little longer. Sometimes you'll end up identifying a protein for which there is no drug that can be used to treat it. And so then comes an additional problem. How do you invent a new drug that is able to inhibit that particular protein? And there are approaches now that are coming on to be able to do just that, but they're more in the area of gene therapy.